It's really mechanisms of action over time. I mean, you just want to get them all in. And so that raises a question that I hear in my clinic. You know, people come in for second opinions. Should I have this or that? And one of the things that comes up is radium only for bone pain? Why would I need that otherwise? And actually, I really do push back on that because radium also has a life-prolonging mechanism of action that we see works. And you know, Ken, you brought it up earlier as being potentially for this patient with bone-only metastatic disease, a completely reasonable option. And so as I'm thinking through the list, if it prolongs life and is potentially going to be effective in my patient, it's absolutely on the list. It's something that we talk about. You know, what do you think?
Yeah, and I think it's critical to use it earlier because, you know, when we looked at our initial use of it, you know, patients were only getting maybe 3 or 4 treatments before they were succumbing to their disease. So we thought, hey, we're clearly not doing something right. So we're really trying to incorporate it as early as possible. And again, I think it's not, I mean, if you look at the indications, it's symptomatic CRPC. So again, it goes to, you have to ask the right question, right? How are you today? Oh, I'm fine. That's not the right question. So, and that's where, you know, we use FACT-P to kind of tease out the symptoms, because I would say that there's probably no man who's got metastatic castration-resistant prostate cancer who's not symptomatic. So it's up to us to ask the right questions so that he can get therapy that's going to prolong his life and get that therapy at a time that it's going to make a difference.
Yeah, can I just, I think your point is spot on. I've seen some data that urologists who have clinics like you do, not the vast majority of urologists in the country who are not necessarily treating, you know, CRPC. There's a bit of a differential between the use of radium more aggressively prior to instituting chemotherapy. You know, part of it may be, you know, medical oncologists' absolute long-standing history of using chemotherapy as a sort of more of a go-to, concern that maybe they won't be able to give the chemotherapy post-radium, which has been disproven. And I think there's even some that don't really understand, to your point, that this is a drug being given for survival prolongation. You know, the Alsimca clearly showed that. Hoskins published in Lancet, pre-chemo was a 4.1 month median OS versus a 3.1 post-chemo. So their data is really strongly there. Now, and it's so well tolerated, and I'm careful to use this word well tolerated. You know, we have to be careful about saying these things. But the level of grade 3/4 AEs is really rather remarkably low. And so, you know, I think that's part of the education that still hampers radium.
You know, and if I may interject, you know, I think one of the concerns to your point is that I don't think they still, even 2, 3 years, 4 years later after its approval, you know, there is still the people don't understand the difference between a beta emitter and an alpha emitter, right? And people perceive Radium-223 as maybe is one of those older radionucleotides that we used to use that were somewhat toxic, great for palliative intent, but somewhat toxic. But also that if you look at the Alsimca, the makeup of the trial, roughly 40% of people did not take any opioids, right? So that means people who actually we would have defined as asymptomatic or minimally symptomatic patients because they're taking over-the-counter NSAIDs but not opioids. And lastly, the misconception of if I get DOSI, what is the if I get Radium-223 and then I come back to chemotherapy, there's going to be a significant side effect profile. If you look at the grade 3 and 4 for thrombocytopenia and for neutropenia, thrombocytopenia, and anemia, the difference between, at least for neutropenia and thrombocytopenia, goes from 1 to 2%. The incidence of grade 3 neutropenia with docetaxel and even febrile neutropenia is between 6 to 12% in docetaxel in the TAX 3 to 7 and SWOG 9916. So I always argue, if the concern that you have of using Radium-223 is a side effect, please give me a better explanation. If you don't like it, I'm okay with that, but it cannot be toxicity dependent, right? And lastly, is that how do you define who can get radium and who should not? The median number of cycles given in America is around 4, right? And most people who actually cannot get beyond 4 cycles is because they either start too late or because they have progression, right? So, but I would argue that our expanded access data in the States is around 4 cycles. But we don't know the time to pain control on Radium-223. We know a little bit of the early data, but the reality of it, if you see someone with pain, and that pain is multi-level, if you will, that patient should not get Radium-223. That patient needs systemic chemotherapy. So when time to pain control is critical for you and your patient, I would not I would make that distinction between chemotherapy and radium-223. If you have the time because you have isolated bone pain, maybe even you do palliative radiation and come back with radium-223, or maybe you start the patient radium-223. But if someone is actually really crippled with pain, which could have been a patient who could actually enroll on Alzheimer's, in my clinical opinion, that patient is not an ideal candidate for radium-223 because you don't have the time for radium-223 to kick in and work for that patient.
So incredible discussion here, really focusing on mechanism of action, personalizing care. What are your thoughts, Neil? Closing thoughts.
So closing thoughts, I like to quote Johann de Bono, who says, it's getting really complicated. So mCRPC, advanced prostate cancer, I think it's really fun as a researcher and a clinician, and I say that in the spirit of great, exciting new data, which we've covered in mCRPC today, and MHSPC, and also in mCRPC, the trials. Every one of our congresses, internationally, it's really tremendous. The intellectual vigor of it is incredibly breathtaking to me, which I think also helps this whole overarching concept that people talk about burnout. You can't get burned out when you're getting great new data and options for our patients. But it is complicated in that you have to keep up with it all, and I think the multidisciplinary team is essential. And we keep adding more components to it: interventional radiologists, geneticists, counselors, learning within our own clinics how to counsel, cardio-oncologists, the pathologists, et cetera. So I think it's a wonderful time. We still have unmet needs, and we need to continue to address them with proper trials.
For me, I think it's all about hope. I say this all the time, but I think this is a great time for our patients. There's a tremendous amount of hope. There's so many new things that are coming out, that have come out. We're turning this into a disease of chronicity so that these patients can get to all those family events that they want to get to. And we just keep telling them, we want you to keep going longer and longer because there are new things that are going to be out there. So that's the most important thing, I think, for me, is the hope for these patients to live longer. And then that goes with the customization of care that goes with it.
And just to complement that, there is no doubt that because of what we have done, over the last 10 years, there has been a drastic shift in mortality in prostate cancer. And I would argue most patients with castration-resistant disease would probably have shifted that completely to the right, and more men are living longer, which again resonates our quality of life. It's about quality, no quantity sometimes. But I think fundamentally, from the biology perspective of prostate cancer, I think that this is the year that actually we will say, after 2019, the molecular revolution and the molecular treatment approach for prostate cancer began. And I think the PROfound will demonstrate that. And I'm hoping, that with more molecular therapeutics, we're going to be able to actually, we didn't have even time to talk about radioligands and PSMA-bound antibodies and CAR-T therapy and immunologics, but the reality of it, I think the future is bright for our prostate cancer patients, and certainly for us who are vested in to do what we do for a living and trying to help our prostate cancer patients.
Absolutely. So personalization of care, hope for the future, and multidisciplinary care to support our patients both in disease-directed therapies, but in all the supportive care and counseling needs that they have. So really wonderful discussion. So thank you, Dr. Schor, Dr. Kernan, and Dr. Garcia for your thoughtful case presentations and a really lively, informative discussion. To our viewing audience, thank you for joining us for this Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic.